My name is Dr. Anam Malik, and I'm working as a fellow in urogynecology and pelvic reconstructive surgery at Aga Khan University Hospital, Karachi. It is an honor and privilege to welcome you all to the second IRC RCOG Summit held here at Shalimar Hospital, Lahore. Today, we are very fortunate because we are having an outstanding lineup of speakers who will be sharing their profound insights and cutting-edge expertise in the field of urogynecology and pelvic reconstructive surgery. At this point, I would like to invite our esteemed expert panel to the stage. They will be leading an engaging discussion, and they will provide their invaluable perspective on today's topic. They will also assess the oral presenters on the sheets that will be provided to them. And also for the young researchers, we do have the cash prize award for the first, second, and third positions. And for oral presenters and the poster presenters, we're also having first, second, third certificate awards. So with this, I would like to invite the expert panel on the stage. So we have Dr. Azizun Nisa. She is the president of Society of Obstetricians and Gynecologists of Pakistan and a leading urogynecologist at Ayub Teaching Hospital. She is a key advocate for advancing women's health care in the region. Dr. Azizun Nisa. No? Okay. So we have Dr. Rani Thakur. She is the president of the Royal College of Obstetrician and Gynecologists. She is an internationally recognized leader in the field, dedicated to improving maternal and reproductive health worldwide. So next we have Professor Shabeen Naz Masood. She is the professor of obstetrics and gynecology at ISRA University and Medicare Cardiac and General Hospital and Jinnah Medical and Dental College. Next we have Professor Shafiq Ahmed of Gynecology and Obstetrics, former Dean of the Postgraduate Medical Institute, Peshawar. He is a respected figure in the field with decades of academic and clinical experience. We have Dr. Tayyiba Wasim. She is the head of Obstetrics and Gynecology Department at Services Hospital, Lahore. And we have Dr. Y. Young. He is the consultant obstetrician and urogynecologist at North Middlesex University Hospital, London. He is an expert clinician dedicated to improving surgical and medical outcome in women's health. So to the expert panel, I would like to kindly request Dr. Rani Thakur and Dr. Shafiq Ahmed that they will be concluding the session at the end with their expert remarks and final thoughts. And also, I would like to inform everyone that we will be holding a dedicated question and answer session at the end of this urogyne presentations. And so I kindly request you all to kindly hold or save your questions until then. So before we begin, I would like to outline the presentation rules to ensure a smooth and timely session. So each presentation will last for 10 minutes, and you will hear a buzzer at the 8-minute mark as a reminder to wrap up your talk. At the 10th minute mark, the slides will be taken down to maintain the schedule. So I kindly request you all to please adhere to this time limit, and we will be very thankful for your cooperation. So we do have expert panel for poster review of the urogyne section. I would be calling their names, and I request them to please get seated on the left side in the third row. So we have Dr. Azra Saeed Awan, Dr. Farida Kakar, Dr. Nahid J. Farooqi, Dr. Nasira Tasneem, Dr. Shaila Anwar, and Dr. Shamila Munir. So our panelists will be reviewing the poster presentations for this urogyne sessions from the 12:30 p.m. to 1:30 p.m. So we kindly remind all poster presenters to be at your respective posters ahead of the judges' arrival to engage in discussion and answer any questions. Thank you so much for your attention, and we look forward to your engaging discussions. Now, without further delay, let's welcome our first speaker to the podium to kick off this exciting session. So first, I would like to invite Dr. Joshna Acharya. She is the South Asian representative of RCOG, and she would be talking about wider effects of implications of menopause. Dr. Joshna.
Assalamu alaikum to everyone. Good morning. Thank you very much for attending this conference in full force. I know Dr. Nazli Hamid has put in a lot of effort with her team. So I'll start the talk without wasting much more time. So I'm going to talk about wider effects of menopause and its implications. I'm Jyotsna Acharya. I work in the UK at Macclesfield Hospital. I'm also the South Asia representative at the RCOG Council. So I would be really interested in knowing what your opinion is. If you have any thoughts for the college, please come and meet me. So menopause is an area of transition. It's when, it's a physiologically and psychologically challenging time for women. We all know that. And the time of menopause lasts from 45 years to 55 years. But we do know that in South Asia countries, women do undergo menopause earlier. So I think the age for menopause in South Asia is about 47. And this is the time when there is irregularity of menstrual periods. It can be heavy periods. They are very, very troublesome for women. But they also, on top of the period problems, they also have symptoms, such as vasomotor symptoms of menopause, hot flushes, night sweats, fatigue, insomnia, body aches, joint pains, psychological symptoms like poor concentration, forgetfulness, low mood, anxiety and low confidence. Sometimes, we don't actually attribute this to menopause. We think, this is aging process. This is, what is expected. But actually, it's interesting to know that these are all linked to the menopause and the drop in the hormones. And then there is sexual symptoms such as reduced libido and sexual responsiveness. And again, women are very, very reluctant to come and complain to you about their sexual issues. And then we are talking about urogenital problems. So urogenital problems like vaginal dryness and atrophy are a well-known problem with menopause. So these are all the symptoms that women have when they undergo the menopause. But we do find that women from the South Asian background are very reticent or reluctant to come up with all the symptoms that they suffer from. They just think it's part of aging. So I think we as gynecologists and their clinicians, first of all, we need to be educated ourselves in the symptoms and the effects, and then we can actually help our patients. So perimenopause is, again, because I'm short of time, it's just when the quality of life is affected and women are really troubled with period problems and things like that. So worldwide, obviously we all know that we are all living longer. So because of the increased lifespan, it's found that 1/3 of a woman's life is spent after the menopause. So it is really important to understand the menopause process and see what we can do to make a difference to lives of women. So, but we know that many cultures and areas of the world, menopause is actually not considered an issue. We just think, it's part of aging, periods stop. Actually, some people are happy that the periods stop, but we don't consider the downsides of period stopping because there are a lot of health issues. More and more research is coming up, which is showing the issues that can happen with menopause. There's a wide variation depending on the culture, race, and the region of the world where, women do present with menopausal symptoms or not. So emotional well-being is one big thing linked to menopause. So we do know not just emotional, cognitive effects can also be affected with menopause. So there are things like brain fog, anger, crying spells, depression, irritability, loss of confidence, loss of self-esteem, loss of joy, mood swings, panic attacks, poor motivation. So these are all can be actually because of other reasons, but many of them are because of menopause. And 63% are affected by poor sleep. It's a large number. 2/3 of women after the menopause have problems sleeping. So I think there is something in knowing about how we manage these. The treatment options we have is CBT, antidepressants, mindfulness, but we do have HRT. I don't know whether HRT is freely available, hormone replacement therapy or menopause hormone therapy, MHT. Is it available in Pakistan? Yes. So that is something we can give these women, although it looks like it's not linked, but actually it is linked to the menopause. I'll not take you through a busy slide, but work is affected, and there are lots of studies looking at work, performance of women after the menopause in the perimenopausal age group, and they find that they're finding it harder and harder to keep up the working hours that they used to. They don't have the stamina to work. So again, if we can treat it or manage it for them, they'll be so grateful. And I think we as doctors also need that, don't we? So at workplace, there are lots of things that we can offer. We can offer a healthy lifestyle like self-help, yoga, sustainable interventions for the future, and all sorts of educational sessions. So I'll just take you through this is from my workplace. I work at East Cheshire NHS Trust, Macclesfield Hospital, and in the intranet, we have got this menopause and workplace website. There are a lot of self-help stuff in there. So, anybody who's in the menopausal age group, they can go in and look up things that they can help themselves with. And I think I would urge everybody to have this in their workplaces. So let's look at the symptoms. So vasomotor symptoms of menopause, the hot flushes and night sweats. Are they just a nuisance? Are they something which you have to suffer and then for a few years and then after that you get better? But there's more and more evidence now which is emerging which shows that women who have longer duration of hot flushes and night sweats are actually prone to cardiovascular disease and depression. There's a direct link to that. So I think that is something we all need to be aware of. If somebody has a longer duration of hot flushes or more severe hot flushes and night sweats, then they are more at risk for MIs, they are more at risk for strokes and depressions. What about the gut microbiome? There's a lot of evidence now on gut microbiome, and this is just emerging evidence. What has been seen is that with the menopause, estrogen and progesterone levels drop, and because of that, the gut microbial composition changes, and that can lead to cognitive changes in the brain for women. What about urogenital symptoms? We are talking about urogynecology, so we really need to be aware of the urogenital effects of menopause. Estrogen receptors are present in all parts of the body, but if you're looking at the urogenital tract, they are present in the squamous epithelium of proximal and distal urethra, alpha receptors in the urethral sphincter, trigone of the bladder, uterosacral ligaments, pelvic floor musculature, vagina. So when there is shortage of estrogen, which happens with menopause, there's shortening and loss of elasticity of the vagina and reduced secretion, thinning of the vaginal mucosa, and therefore women suffer from dyspareunia, they suffer from urinary symptoms and all sorts of symptoms. The simplest way to manage it is with vaginal estrogens. If you can give your patients vaginal estrogen, either in pessary form, cream form, or any form, then you will find that their symptoms are much more relieved and their urogenital symptoms are better as well. So we class this as urogenital syndrome of menopause, where the symptoms are genital symptoms, sexual symptoms, and urinary symptoms. And they can present between 3 to 6 years after undergoing the menopause. That's why sometimes we don't make the link between menopause and the urogenital symptoms that women have. But actually, this is linked to menopause. And up to 60% of women and up to 25% of women, even after using the HRT, or hormone replacement therapy, can still have urogenital symptoms. And the best way to manage it is by local estrogen, by vaginal estrogens. So this is the management: lubricants, topical therapy with vaginal estrogens. And in UK, we actually have ospefin, which is given orally. This is a SERM, a selective estrogen receptor modulator, and which acts to the binds to the estrogen receptors, because some women don't want to use vaginal estrogen. They don't want to go near that area at all. So for them, this is good because it's given orally. And then there are emerging evidence for laser therapy. And in UK, we also have DHEA, which is dihydroepiandrosterone, which is called prasterone, which is, again, a pessary which is inserted every day. And it gives androgens as well, which is even more beneficial. So what are the other effects of menopause? You know, we see women coming in their late 40s and 50s saying they've got joint pains, they've got aches and pains, they can't move as much as they used to. This is all linked to menopause. Up to 50% of women experience arthralgia or arthritis. And this is again because of drop in sex hormone. But more importantly is sarcopenia, loss of muscle mass. You know, do you know that there is a decline of 0.6% of muscle mass per year if we don't treat sarcopenia? And women are losing their muscle mass, and then it can lead to fibromyalgia, but it can also lead to balance issues, gait issues, and things like that. So we can replace with HRT, but if the women don't want HRT, there are other measures that we can use. Okay? But we need to educate our women that they will lose muscle mass if they don't do anything about it. The best way to treat, if you don't want any medications, is body weight exercises or resistance exercises, yoga, things like that. What about chronic medical conditions? I touched upon it earlier, but there is a lot of evidence now linked with menopausal symptoms such as hot flushes as a biomarker for chronic health problems later on. So if you intervene and give hormone replacement therapy or MHT in the first 10 years of a woman undergoing menopause or below the age of 60, this is called the window of opportunity. This is when you can make a difference to the future life of that woman, because chronic health conditions and aging processes can be reduced. So please consider this because there's a lot of evidence for this. What about premature menopause? We do see, don't we, that many women are undergoing menopause very early on, even before the age of 40. And what new studies have shown that they can actually affect the cognitive function. They lead to cognitive decline. So therefore, if you are replacing with HRT, hormone replacement therapy, then you are actually doing a favor to these women. I think one take-home message, if you can, from my talk, is if you see a woman who's undergone menopause in her early 40s or below the age of 40, please give them hormone replacement therapy without thinking about the side effects, without anything, because we start considering the side effects and the ill effects of hormone replacement therapy after the age of 50. So before the age of 50, please give them replacement, because you're doing them a favor by helping them with their muscle, with their cardiovascular health, and their general well-being, mental health and cognitive health. So this is the other one. You know, we do perform surgical menopause. We give GnRH analogs, medical menopause for endometriosis and things like that. Or we need to do it for cancer surgery. If you are removing the ovaries for a woman because of whatever reason, or you're shutting down the ovaries, please replace with hormone replacement therapy. You can give Tibolone, which is freely available, 2.5 milligrams once a day, but you need to replace that. Otherwise, you are doing a disservice to the patient. Mental health, I thought this is very interesting because there was a survey of more than 5,700 women in the UK, and do you know what they found? That nearly, large number, 94.6% had experienced some sort of negative mood changes or emotions in the perimenopausal or menopausal period. And out of these, nearly 20% were diagnosed with depression or mood disorder, needing some sort of treatment. So menopause can lead to mental health issues. But also, this is very interesting slide. In the UK, the highest suicide rate in females is actually seen between the age of 50 to 54. Can you imagine that? Because we see that all mental health conditions are more in adolescents, in the young adults. But actually in women, it's in the menopausal age women. And also schizophrenia, which has a typical onset in early years, actually has a second peak in women in the menopausal transition period. And bipolar disorder as well. So there is a strong link between mental health disorder and menopause. What about osteoporosis? It's a big health condition, and it has a large economic burden on the government. Osteoporosis, 1 in 3 women compared to 1 in 5 actually have osteoporosis. And we all know that lack of hormones with menopause leads to osteoporosis. And fractures of the wrist, hip, and vertebra impact the quality of life, increase the economic burden, and excess mortality. I got figures from India because, they had studies. So in India, and I'm sure it will be very similar here in Pakistan, India, the incidence is estimated to be 120 fractures per 100,000 persons over the age of 50. And that has a big impact on their future life, their productivity, and things like that. So treatment of osteoporosis, I won't bore you with all the treatments for osteoporosis, but the first one, I want you to direct you to the first one, which is hormone replacement therapy. So we do a favor to a woman who has osteopenia or a strong family history of osteoporosis if we can replace her hormones with hormone replacement therapy in menopause transition. So I hope I have managed to convey the wide range of effects that menopause has on women's health, and thank you for your patient hearing. I hope I was stick to time as well. Thank you.
So now I would like to invite Professor Pushpa Sirichand. She is a distinguished obstetrician, gynecologist and urogynecologist at ISRA Medical University, Hyderabad, founder of the Pakistan Urogynecology Association and an expert in fistula surgery. She presents her study on urogenital fistula at Tertiary Care Hospital. Dr. Pushpa.
Good morning and assalamu alaikum to everyone. May I have the first slide, please? Actually, the topic which has been assigned to me is a urogenital fistula and the study which we have performed at Tertiary Care Hospital. Urogenital fistula, it is not a simple hole. It's a hole which drains the entire life of a woman with a continuous urinary leakage. Globally, more than 2 million women, they are left untreated with vesicovaginal fistula. 50,000 to 100,000 new cases, they occur each year. The tragic story is that 80% they are from developing countries, mainly from Asia and Africa. About Pakistan, 4,000 to 5,000 new cases of vesicovaginal fistula, they occur each year in Pakistan. For every maternal death, there are 10 to 15% of women which suffer from serious complications. And in my opinion, the worst complications are fecal and urinary fistulas leading to a continuous urinary and fecal incontinence. Talking about the etiology of vesicovaginal fistula, there are three main causes. One is still, although the obstetrical fistula, they have been eliminated from developed countries, but still in the low resource countries, we are getting patients with fistula after obstetrical labor. And in my opinion, the fistulas resulting from obstetrical labor, they are the worst complex fistulas in comparison to surgical fistulas. Another common cause of fistula is because of cesarean hysterectomies due to morbidly adherent placenta. And nowadays, we are receiving young women. They are having fistulas after first intercourse. You can see the figure at the left. She was a young girl who was referred to us, and she had a very large sulcal tear on her first wedding night involving anterior, lateral, and posterior vaginal furnaces, and she developed VVF. Why there is a rising rate of iatrogenic fistulas? It's because of rising cesarean section rate, hysterectomies usually being done without a valid indications. It's an easy accessibility to a surgery because now the gynecological surgeries, they are being performed everywhere. And these surgeons, I am sorry to say, not all, but in few small maternity homes, they are not properly trained in these surgical procedures. This was the data when I was working in Liaquat University Hospital, where we started the project in 2007 and up to 2010. We repaired 176 fistulas. And you can see, previously we used to get more obstetrical fistulas, but now we are getting more iatrogenic fistulas. So far, we have repaired 1,189 patients with a vesicovaginal fistula, and commonest being vesicovaginal fistula, which is an abnormal communication between the vagina and bladder. If you look at this, you can find there is a rising trend of iatrogenic fistula. Previously, we used to get more obstetrical fistulas, but now we are getting more iatrogenic fistula, which results from a surgical error. So this is a graph which is showing a trend of rising iatrogenic fistula in comparison to obstetrical fistulas. We compiled the data in Isra University Hospital from 2017 to 2024, and during this time period, we received 622 patients, where about 347, they were iatrogenic. Well, it is really difficult to place them into iatrogenic and definitely obstetrical. But in our study, about 16% they were likely iatrogenic. There were those women who had obstructed labor, ended up in a cesarean section and a vesicovaginal fistula. So probably it was as a result of obstructed labor and obstetrical fistula. Probable iatrogenic. These were following cesarean hysterectomies. Definitely iatrogenic. Those fistulas which were ureteric due to ureteric injuries, gynecological vault fistulas following hysterectomies, and those which were due to cesarean section, but they delivered an alive babies, most probably they were definitely iatrogenic. There was a surgical error which was responsible for these fistulas. We tried to find out what was the cadre of staff performing these causative procedures leading to a fistula formation. When looked into it, the cesarean sections, majority of 71% of these cesarean sections, they were performed by medical officers. Cesarean hysterectomies, about 66% they were performed by the medical officers, and only 8% they were performed by the specialist. Gynecological hysterectomies, 67% they were performed by medical officers at small maternity homes, and only 17% they were performed by specialists. So looking at this chart, we can say that cesarean hysterectomy due to abnormally adherent placenta, it should be performed by a senior, not by a medical officer or a registrar, who are not properly trained. Coming to a socioeconomic and demographic characteristics of these fistula patients, of course, post-hysterectomy patients, they were in an elder age group. In comparison to obstetrical fistulas, they were very young and they have a very complex fistulas. Marital status, only 2 patients, they were not married. And there was, in both the tragic story was, both these patients, they have an unwanted pregnancies which ended up in a fistula. Then majority of them were married. 33% in ischemic fistula, 33 patients, that is 15%, they were having ischemic fistula, 125%, 125, that is 30%, they were iatrogenic. And of course, patients having hysterectomy, they were multiparous women, and patients having obstetrical fistula, they were nulliparous. So here we wanted to see that we are receiving patients not only from Sindh, but from other provinces of Pakistan. Well, here you can see, this shows the trend in the etiology of iatrogenic fistula. You can see a graph, and majority of these patients is received as a post-hysterectomy fistulas, and these hysterectomies, they were done for gynecological cases. What are our challenges? Elimination of obstetrical fistulas. By good antenatal, intranatal care, postnatal care, we can eliminate this complication. Look at this woman. She had a polio. She went in obstetrical labor, and she developed a fistula. Young girl, only 16 or 15-year-old, had a first pregnancy, developed VVF, RVF, and foot drop. Still, we are receiving patients. You can see the fetus is delivered through the perineum. Vault was stitched with the proline, which formed a nidus, and a stone, which eroded the vault of vagina and bladder. What we have so far done for prevention and treatment of these fistulas? We have been arranging various workshops, awareness programs for prevention of obstetrical and iatrogenic fistulas and on their early management. So these are the workshops we have been performing. Awareness, International Fistula Day, we celebrate, and we do an awareness programs on this, on audiovisual programs. Well, we train the community health workers and lady health workers how to recognize early obstetrical labor, when to refer them, how to refer them, where to refer them, and to prevent the development of obstetrical fistulas. How they are being trained. Other challenges is we have to find out the hidden cases of fistula because they are coming to us very late. So these are the challenges we are facing, and we can reduce not only prevent the development of fistulas, but we are training the doctors, if they receive patients with a fistula, how to manage them. So our mission is prevention and management of patients with vesicovaginal fistula. Thank you so much for patience listening.
So now let's move on to our next speaker. She's Dr. Majida Zafar. She's an assistant professor of Mother and Child Health Center at Pakistan Institute of Medical Sciences, Islamabad. She shares insights from a 4-year review of vesicovaginal fistula repair, addressing its challenges and success in a tertiary care setting.
Assalamu alaikum everyone, and thank you Dr. Pushpa for setting up the stage for my presentation. I'm Dr. Majida Zafar, working at MCH PIMS, and this is a brief overview of our fistula project where we are working. So the fistula project of MCH PIMS was inaugurated in 2007 by the Executive Director of UNFPA under the leadership of Professor Ghazala Mahmood. Then this project worked successfully under the leadership of different heads, And currently, Dr. Sobia Lukman is the managing director of this project. She is working under the leadership of the current head of the unit, Professor Noshila. And here I would like to mention the name of Ms. Athar, who is actually our coordinator for the patients, for all the clinical and surgical trainings, for preventive programs, and for the rehabilitation of the patients, because our center is not only the clinical or the surgical treatment center, it also offers the preventive therapies, the workshops, and the rehabilitation of the patients who are all registered with this center. Our fistula project under UNFPA is one of the 8 regional centers which are working in different cities of the Pakistan, and we work in collaboration of 4 specialized centers. Our collaboration is mostly with the center at the Kohinoor, and we are thankful to Dr. Pushpa and Dr. Shersha for sending the fistula-trained surgeons to our center, for imparting us the surgical training, for managing difficult cases, and also for improvement in our surgical care, and they manage the difficult cases which we have imparting surgical techniques to the young gynecologists at our center is actually very important for us. So I'm going to give just a brief overview of the vesico-vaginal fistula repairs at our centers. Approximately 200 patients presented to us in these 4 years from 2020 to 2023. And what we have seen is that the vesico-vaginal fistula, they actually varied between 11 to 40% in these years. The total number of patients of vesico-vaginal fistulas in these 4 years were 135. And out of these, we have seen that 105 patients, they were repaired using a vaginal route of repair of vesico-vaginal fistulas. And only 30 patients were repaired using an abdominal route. And I'm going to explain and I'm going to express our thoughts and what we have observed in these vaginal repair routes, their success rate. Vaginal approach had a higher success rate in our setup, approximately 95% compared to the abdominal approach, which is 90%. The success in our setup, we have determined it with absence of urinary leakage over a period of 6 months post-operative. Abdominal approach for VVF repair was used only for complex or recurrent fistulas. And post-surgical complication, including recurrence of the fistulas, was also more common in the patients which underwent an abdominal approach, which was 10% versus 4.3%. So this is the comparative analysis of both the routes of repairs, vaginal versus abdominal route in VVFs. We have seen that there was 50% reduction in the hospital stay of the patients who underwent vaginal route repair. The blood loss was also significantly less, and the operative time is also less in case of vaginal route repair. And then the recurrence of fistulas. It has a significant impact, only 4.3% versus 10% recurrence in case of abdominal route repair. So we claim that the success rate of fistula repairs is more, and it is significant in case of a vaginal route repair. So the vaginal approach which we use in our setup is a simple flap splitting method, which involves widely separating the vagina and the bladder mucosas all around the fistulous tract, and then suturing them into 2 layers and avoiding the tension on the sutures. So by this simple technique of vaginal repair, we are actually attaining the success rate. In very few cases, we use omental grafts or Marshall's graft, which are very rare in use. This is just a simple representation, that identification of the fistulous tract. Even the ureter catheterization is not mandatory for all the simple fistulas. The vaginal epithelium is then mobilized over the bladder, and simple suturing in 2 layers. It is the best, simplest technique for the young gynecologists who are not very well trained in the advanced surgeries, and they can prevent a lot of complication by this simple repair. So what we have seen in our center is that for simple fistulas, the success rate is comparable to any other skilled surgeons. The vaginal route is preferred for low and simple fistulas, and abdominal route we recommend only for high or recurrent or complex fistulas. The post-operative outcomes in both the routes have shown that vaginal repairs they result in the less post-operative morbidity and a quicker return to normal activities after these repairs. Patient satisfaction definitely owns to the shorter recovery times and contributes to the higher satisfaction rate. And as it is a less invasive technique, that is why most of the patients and the surgeons, they appeal for the vaginal root repair. However, the challenges are definitely there's a limited access to complex or higher fistulas and surgical expertise, which we are here that we need to develop our surgical expertise in the vaginal repair. And we are thankful that our fistula-trained surgeons from the specialized centers, including Dr. Pushpa, they have frequently visited and they have encouraged and trained us in the vaginal root repairs. Fistula is managed usually or traditionally by gynecologists, and we actually repaired mostly the obstetric fistula. Definitely now the pendulum has swung from obstetric to iatrogenic or surgical fistulas, and there is a need for involvement of urologists also because they know the complexities and the involvement for complex urological reconstructive surgeries is most often required. We, being gynecologists, prefer vaginal root repair because of less complications and easy access and easy surgical skills. Urologists mostly prefer the abdominal route. So we want here to recommend that there should be a collaboration between gynecologists and urologists for actually finding out the path and then designing how we are going to repair these fistulas. So we recommend that ideally the vaginal fistula repair should be done with a multidisciplinary team involving urogynecologists for precise diagnosis and designing the surgical care for the fistula management. There should be enhanced training programs for better surgical procedure, for better repair, and improving our skills in the minimally invasive surgeries and reconstructive surgeries. And we need to have an integrated urogynecological expertise for better operative and rehabilitation cares of all these fistula patients. So thank you everyone for your patient listening.
So up next, we have Dr. Urogy Kashif. She is the Assistant Professor of OBGYN Department at Aga Khan University Hospital, Karachi. And she is also the Program Director of Urogynecology and Pelvic Reconstructive Surgery at Aga Khan. She would be discussing surgical outcomes of mid-urethral sling surgery and its long-term effects on quality of life during the era of mesh controversy.
Good morning, ladies and gentlemen. Thank you, Anam, for your kind introduction. I'm Dr. Urogy Kashif. My introduction has been done. So let me tell you the background of the study. Can I have my slides, please? We all know that mid-urethral stress urinary incontinence affects approximately 15 to 35% women population all around the world. Among them, 13%, the complaints of those patients, they would be needing, 13% of them would be needing operative treatment. So mid-urethral slings were introduced in 1990. And after that, very quickly, they became the gold standard of the treatment for stress urinary incontinence. So in 2008, FDA just gave a statement against the vaginal meshes. And mid-urethral slings were mistakenly, they were drawn into the controversy of vaginal meshes. After 2011, all the continence society and the evidence were coming, they were supporting the mid-urethral slings. Now we all know, after that mesh controversy era, that mid-urethral slings are the best effective treatment for the women with stress urinary incontinence, and a woman should not be deprived of the standard quality of care as a result of mesh controversy. With background, can I have my slides, please? Okay, sorry. All right, so with that background, we needed with this background of mine, we needed some data of our population. The area which we living, we work, majority of in our population, they are living in the low resource setting. Even we are not having the proper mesh devices and the trocars. So up till now, there wasn't any study in Pakistan done to see the outcomes and the safety of these procedures. So objective of my study was to evaluate the safety of mid-urethral slings in terms of long-term or post-op complication, its effect on quality of life, and to assess the subjective and objective and overall success rate over the period of 10 years. So I work in a private university, which is the biggest private university of Pakistan, and we are not the true representative, but we maintain a very good medical record. So we went through the 10 years data. We were performing those surgery for the past 20 years, and we found out that we have operated on 345 women during this period. We developed a structured questionnaire, or you can say a data retrieving tool, to look at the retrospectively charts of those patients. So my secondary outcomes, main outcome I have already discussed. Secondary outcomes were improvement in quality of life, assessed by using IIQ-7 and short form of UDI-6. Safety was measured by incidence of intra and post-op complication of both procedures at 1, 12, and at least 30 months, which should be the standard for an operative procedure to be assessed for the safety. So these were my demographics. As you can see, we have done an incidence study in our population too. As we can see, these are matching with the risk factors of the stress urinary incontinence. Like those, majority of them are menopausal, multiparous with high BMI. The procedure which were done was TVT, TVTO, and outside in. This was the number distribution of the procedures. And we look at the stage of the prolapse too, because we had some of the concomitant surgeries too. Those were 221 in the vaginal hysterectomies, suspension procedures were done. All right, so now the important part, the intra and post-operative complications. So like any sling surgery, especially the TVT we saw 8 bladder injuries. There weren't any urethral injuries, and we saw hematoma which required admissions in 2 patients. So as you can see, sorry for the disalignment of the figures, we had urinary retention in 10 of the patients, in which TVT has the highest number. So at 12 months, patient reported LUTS too. This is the known complication, and some of them reported dyspareunia and hyspareunia too. And as expected, approximately 5.7% of the patient faced voiding difficulty. And as you can see, the numbers were decreasing with the 30 months follow-up. So our main outcome, the MASH-related complications. We didn't see any infection, overall rejection, or erosion into the organ. So I omitted that point. So they were very less exposure, 10%, at 1 month follow-up. At 12 months follow-up, 7 of the patients reported with exposures, and 30 months, few of them reported, 4 of the patients reported the exposure. Extrusion was seen in 1 patient only. So those were really surprising results, because our results of mesh acceptance in our population, we found out it very good. The reason we belong to a different ethnic group, the reason the surgery was done by 2 or 3 persons, the reason fellows or the junior doctors were supervised by direct supervision, and as this evidence states that the person who is performing those surgeries should be well-trained and properly trained and supervised. So in safe hands, we found out that procedures were working very well for our population. So these were the success results as expected. They were very above 90% success rate. And as expected, we saw a significant improvement in quality of life in patients in form of these questionnaires. So conclusion, so far now, with urethral slings in our population that is now parallel with the evidence coming, is safe to perform. And limitation of the study was the follow-up. It was like 30 months. It can be 5 years too now. Retrospective design was the urodynamics. We didn't perform urodynamics all of the patients. And this study was single center. So we need more study like that, and someone is doing that, so they can contribute for the safety of these procedures. Thank you.
So now let's welcome Dr. Shima Yusuf to continue the conversation with her work on the outcomes of concurrent prolapse repair and stress urinary incontinence surgery in a pilot observational study. Dr. Shima Yusuf is a fellowship resident in urogynecology and pelvic reconstructive surgery at Shalimar Hospital, Lahore.
Thank you, Dr. Anam, for calling me on the stage. So today I am going to present our work on concurrent surgery for prolapse repair and stress urinary incontinence. It is a pilot observational study. As urinary incontinence is a distressing condition which affects 26% of women in the developing countries. And pelvic organ prolapse and stress incontinence coexist in 54% of women globally. Currently, there is insufficient evidence that concomitant surgery for prolapse and incontinence is beneficial for reducing the post-operative stress incontinence. We aim to compare the outcome of patients undergoing combined surgery versus pelvic organ surgery only. So a pilot observational study was designed and it was performed in the Department of Urogynecology, Shalimar Hospital, Lahore, from 1st of February 2024 till 31st October 2024. Total of 17 patients of 41 to 83 years of age presenting with the complaint of pelvic organ prolapse and stress incontinence were added in the study by convenience sampling. Patients were divided into two groups. Group A were those who were undergoing concomitant surgery for prolapse and incontinence, and Group B were those who had prolapse-only surgery. The techniques allowed for vaginal prolapse surgery were based on the stage and compartment of prolapse and is left for the surgeon to decide. Transobturator and retropubic tabs, Burge corpus suspension, and pubourethral ligament plication were allowed for the stress incontinence surgery. The inclusion criteria was women presenting with pelvic organ prolapse and stress incontinence and those who are willing to undergo the surgery. We excluded the women who were having urge incontinence, urinary tract infection, who were unwilling or unfit for the surgery, who had recent prolapse surgery, those having previous incontinence surgery, urogenital malignancy, and urolithiasis. The primary outcome of this study was absence of stress incontinence at 6 months after surgery. And the secondary outcomes included the additional treatment required for stress incontinence and its complications of the surgery. A cuff stress test was performed for objective assessment at 6 months after the surgery. Objective care was defined as a negative cuff stress test. Those who were positive for the cuff test were given further option of pelvic floor surgery or redo surgery. The baseline characteristics were comparable between the two groups. I will show in the table form as well. There was a total of 9 patients who underwent prolapse-only surgery, and total 8 patients were those who had prolapse repair along with the anti-incontinence surgery. The mean duration of surgery was 113 minutes in combined surgery group and 70 minutes in the prolapse-only surgery group. Average stay in hospital was 3.3 days in the combined group and 2 days in the prolapse-only group. This table is showing the baseline characteristics of the participants. As we can see, the age, parity, BMI, in the both group of the participants in the both groups are comparable. However, the duration of surgery is a bit longer in the combined group as compared to the prolapse-only group. These were the surgical techniques used during our surgery. In the combined group, we used sacrohysteropexy with Burge corpus suspension in 1 patient, TH with TOT in 2 patients, vaginal hysterectomy with tension-free vaginal taping in 1 patient, TOT with anterior repair in 1 patient, and pubourethral ligament plication along with the anterior repair in 3 patients. In the prolapse-only surgery group, 5 patients opted for native tissue repair of cystocele and 4 underwent vaginal hysterectomy along with the anterior repair. Women assigned to the combined surgery group were more frequently reported absence of incontinence at 6 months after surgery as compared to the control group. There were 75% patients who reported absence of stress incontinence symptoms in the combined group. 2 patients in the combined surgery group who had pubourethral ligament plication, however, reported only partial improvement in their symptoms. The decision to select these patients for pubourethral ligament plication was based primarily on the patient preferences or financial considerations, for example, inability to afford mesh or desire to avoid extensive surgery like Birch-Goldberg suspension. This suggests that pubourethral ligament plication might be a reasonable alternative for certain patient populations. It may offer some relief to the patients with mild to moderate SUI, although not completely cure them. This table is showing the effect of combined surgery. I already explained the results that only 2 patients remained positive for the cuff stress test at 6 months after surgery in the combined group as compared to the 6 patients who remained symptomatic after 6 months after surgery in the prolapse-only group. Physiotherapy was the only intervention opted by the symptomatic patients after surgery. The reason was primarily a decrease in the severity of stress incontinence or the woman's preference to avoid further surgery and the associated risk. In both groups, there were no intraoperative complications. However, the only post-operative complication noted in both groups was transient dysuria, which settled after 1 or 2 days, which can probably be due to the catheterization. So conclusion, women are less likely to have urinary incontinence after combined surgery. However, appropriate counseling of patients about the potential risk and benefits of combination surgery is very important. The risk and benefits should be balanced for the individual woman. We are further doing this, we are continuing this study with a larger sample size and longer duration of follow-up. This is just a pilot observational study, and we have presented the results of the pilot study. Thank you so much.
I want to welcome Professor Ruqayya Sultana. She is an Associate Dean of Research and a leading obstetrician, gynecologist and urogynecologist at Ayub Teaching Hospital, Abbottabad, Pakistan. She presents findings on sacrocolpopexy outcomes and predictors of anatomical failure.
Esteemed members from the Royal College, the senior faculty, and the young, vibrant doctors, Assalamu alaikum. The time is less, so I have to go to my topic directly. My topic for today is outcomes of the sacrocolpopexy and the predictors of the anatomical failure. Why I chose this topic? Because the part of the country from where I have come, it is very common, and especially in the Koistani people who are very thin, frail, of low BMI with weak connective tissue, and they are used to very strenuous lifestyle activities. So before I go to my topic, I would like to share the glimpse of my beautiful institute, Ayub Medical College, and on the right is my mentor, my torchbearer, who has honestly given her skills, expertise to her trainees to make them stand in the world. Thank you so much, ma'am. The background is that vaginal vault prolapse, it is defined by the International Continence Society by the observation of the descent of the vaginal vault, that is cuff scar after hysterectomy. The incidence of post-hysterectomy vault prolapse, it ranges from 1.8 to 11.6% if the hysterectomy is carried out abdominally for benign reasons or for prolapse. And sacrocolpopexy is one of the procedures which treats pelvic prolapse, especially of the vault, by using the mesh to lift the apex of the vagina back to its place. And in experienced hand, it is very successful to restore its optimal surgical outcomes. So whenever a gynecologist comes across a patient whom she has performed hysterectomy and the patient comes back with something coming out of vagina, it is really very, very distressing for her. And it takes a lot of time and to get mentally attuned to this fact that a patient requires a repeat surgery. Now, this is showing the classification of the vault prolapse according to POCU, and my patients were mostly included in the study were from 2nd, 3rd, and the 4th degree. The risk factors of my patients was that they had weak connective tissue, increased intra-abdominal pressure because of the strenuous work, and there were associated medical conditions in the form of hypertension and diabetes. This is a beautiful pictorial presentation of the D-Lancy vaginal supports. I will not go into the details because of the shortage of time, but they need to be kept into mind. And they have to be tightened up to the vaginal vault to prevent the recurrence after hysterectomy, because if they are not taken care of, then what is going to be the disaster is the vault prolapse. The symptoms which mostly presented in my study were a mass coming out of the vagina associated with urinary or bowel symptoms, and vaginal bleeding was present only in few patients who presented with decubitus ulcer. So before going for the management, the important things which need to be considered is the prolapse type, pathology, what is basically causing it, the age of the patient, the lifestyle modifications, the presence of any comorbidities, whether she wants to retain the sexual function or not, what are her expectations after the procedure, and what is the expertise of the surgeon, very, very important. And the pathology needs to be evaluated in detail by MRI, urodynamics for any urinary symptoms, and dynamic pelvic fluoroscopy, especially for the posterior compartment defect. The conservative management, it has go hand in hand, even if when you are performing the surgical measures, because it is part and parcel of the success of the procedure. What we performed was the reconstructive abdominal surgery in the form of sacrocolpopexy. The rationale was that there was lack of necessary data, especially in the South Asian women, especially in my part of the country, understanding the facts that predicted failure, improving surgical planning, patient selection, and post-operative care by filling the gaps to improve the outcomes, and improving surgical technique to tailor the meticulous technique with least failure rate. The study was performed over a period of 3 years, from 2021 to 2024. It was a retrospective cross-sectional descriptive study. The sample size was 30 patients using the non-probability consecutive sampling. After taking the permission from the ethical review board of our institute. Please play the video. So the methodology of the sacrocolpopexy I will discuss here through this video. We do it by open technique. Although the laparoscopy is performed in our centers, but because of being a public sector hospital, we are lack of funds. So mostly we go for the open one. The patient, this has been opened by the previous abdominal or phalansteal incision, whatever is there. After adherolysis, you can see because the hysterectomy has been performed, we are exposing the sacral promontory and the ligament which are covering the sacral promontory, because they need to be exposed. And here, what are anatomical structures which you have to take care? On the right side, the ureter, and on the left side, it is the rectosigmoid junction, which has to be packed laterally, so that there is no important structure in the plane where you are performing the surgery. This is the macroporous polypropylene film sheath which is being used, of adequate length and width, and the upper end of this, you can see here that it has been tied to the ligament which is on the sacral promontory anteriorly. The lower end of the this tape, it has been divided into two, the one being tied to the anterior fibromuscular layer of the vagina and the other to the posterior fibromuscular layer of the vagina. Here you can see that another incision has been made over the vault, which has been lifted up by a deburr into the vagina by the assistant. And after giving a nick on the peritoneum, we are making a tunnel from the vault towards the capillard, towards the sacral promontory, through which we will pull the lower end of the mesh so that it can be tied to the vaginal vault. Here you can see we are retrieving this mesh has been retrieved. Now we are very careful that we don't damage the overlying peritoneum or the structures laterally. The peritoneum over the tunnel is being taken care of so that there are no breaches. Now the adequate length of the sheath, it has been cut so that when it is tied to the anterior and posterior fibromuscular layer of the vagina, the good results are obtained. The prolapse has been corrected. The cystocele and the rectocele which is present, it is also taken care of abdominally so that the patient can have good satisfaction rates post-operatively with good anatomical effects. Now the anterior part on the vaginal vault, it has been sutured, and the suture we use is non-absorbable Prolene suture. Now the defect on the sacral promontory and the vaginal vault is closed, and this you can see the same patient pre and post-operatively. Next, please.
That is the 8-minute timer. You still have 2 minutes.
Okay, I'll just, please move to the next slide. Oh, okay, sorry. So these were the patients' results, the patients presenting with the comorbidities, mostly hypertension and diabetes. The parity was from 2 to 6 mostly. And the important thing was that the prolapse appeared initially before sacrocolpopexy. It was in low BMI, but when the recurrence occurred, it occurred in those patients who were of high BMI. The intra-mean blood loss was 5 ml. There was no complication of bladder, bowel, or urethral damage. And there was 3 cases of vaginal discharge, and 1 was because of mesh erosion, which needed the surgery because of this removal of the exposed mesh. There was no complication of any post-operative like dyspareunia or spondylosis. And the patient satisfaction rate on the whole out of 30 patients was 27 and dissatisfied 3. 1 was with mesh rejection and the 2 were who had the anterior and posterior mild prolapse. And the recurrence was also seen in those patients who had diabetes only, neither hypertension nor any other comorbidity. This explained. So conclusion that sacrocolpopexy is an effective procedure for vault prolapse provided the surgeon has expertise and the patient selection is appropriate. The rejection is dependent on the comorbidities, especially the BMI after the surgery, previous history of prolapse, as well as the health of the collagen tissue, which was very important in our study. So the take-home message that the surgery should fit the patient should not fit the surgery. Thank you.
And remember, if you have any questions, we'll be taking them at the end at our question and answer sessions. Also, I would like to remind all poster presenters to be at your respective posters because the expert panel will start reviewing the posters at 12:30 p.m. So let's now move on to Dr. Aruba Rahim. She is a consultant gynecologist and laparoscopic surgeon at Farooq Hospital, Defense Housing Authority, Lahore. She examines the outcomes of laparoscopic sacrocolpopexy in treating vault prolapse and associated urinary symptoms.
Thank you, Anam. Assalamu alaikum, everybody. So we had very good presentations regarding the mesh repair for the prolapse, vault prolapse. My specialty is the laparoscopic surgery. So I would like to talk a little about the laparoscopic sacrocolpopexy, and at the end also I would like to discuss few outcomes related to this. So Dr. Ruqayya has elaborated in a very well way the whole theoretical part as well, that it's the descent of the apical part of the vagina, and it is when it really happens, it is very disturbing for the patient. Because it really causes very bad symptoms and it affects the quality of life as well. So she really needs good treatment, and if we have some good treatment in the form of mesh, for example, and if it is done in expert hands in a very good and precise way, then we should not deprive any lady of this treatment option. So I have put up this video. We had open surgery. We had the video for the open surgery just now. So now we'll have a look at the laparoscopic sacrocolpopexy, and you will find out that no doubt in expert hands, open surgery really has very good results. But laparoscopic surgery gives you better vision, maybe better results. The precise work is done. How can we play the video? Yeah, thank you. So here we can see the sacral promontory very easily. There is no opening up of the scar or anything. There is that was the sacral promontory, and this is the vault. Inside the vagina, we have the vaginal ball. And as in Pakistan, we have less resources, so we can make our own vaginal ball with the help of a gauze attached to the sponge holding forceps. And then the separation of bladder is very, very important, because the anterior limb of the mesh is to be applied here to the, yes, I have this pointer also. So we need to apply it here on the anterior part of the vault. And so anteriorly, I'm separating it with the harmonic. This harmonic is actually a mechanical electrosurgical device which is used during the laparoscopic surgery. Again, considering our country, if we don't have harmonic device everywhere in our setup, we can even use the monopolar, but for that surgical skills have to be very, very good, and all the precautions regarding monopolar surgery should be taken care of before we use it. Here I'm making the retroperitoneal tunnel from the sacral promontory till the posterior part of the vault, and as we had in our previous lecture, we have the sigmoid and then rectum, and laterally throughout we have the ureter going with us. So we have to be very careful while making this retroperitoneal tunnel, and it is created so that the mesh can be buried inside this tunnel. Now the posterior part of the vault is separated to separate the rectum actually. Here again I have to be very, very careful, because medially I have rectum and above the sigmoid, and posterior separation should also be very good, because again the posterior limb of the mesh is to be fixed to the posterior part of the vault. Excuse me, you have stopped the video. No, it's not the next slide. Yes. So आपने शुरू से लगा दिया, थोड़ा सा forward अगर कर दे. So the mesh is actually the polypropylene mesh, and it is the shape of the mesh is made outside the body, which is we have started the video again. So it doesn't matter. I'll explain the whole procedure otherwise. The mesh is sorry. Please play the video. Excuse me. G. So the mesh is shaped in a Y-shaped manner, as we saw in the previous presentation also, and the two limbs of the Y are placed to the anterior part and the posterior part of the vault, and the longer limb of the Y is then fixed onto the sacral promontory. Here again, patient selection is no doubt very important. Yes, diabetes can increase the morbidity or can affect the outcome, but again, if it is done in a precise way, in very good sterilized conditions, in laparoscopy you have better outcome again. So there were few patients also. I'll show you. I'll try to discuss with you the data also, who were diabetic and they had previous surgeries also, but they had good outcome. And so the tunnel is again. The video is being played again. Here another important thing is, especially for the colleagues, is that we need to be careful about using the suture material that we are using. The mesh itself is non-absorbable, and the suture which is used to fix the mesh onto the vault and the sacral promontory is again non-absorbable. You can use Prolene suture or the Ethibond suture. It's easier to use the Ethibond suture in laparoscopy, and then to fix it on the sacral promontory we have Tecker. Again, it pushes the non-absorbable nail into the mesh into the sacral promontory, but again this Tecker is very expensive in our country. However, it's easily available, but again we can use Ethicon to fix the mesh on the sacral promontory. So here we were, the posterior part of the vault, the posterior rectum is being separated from the vault, so that the space is created to place the posterior limb of the mesh. This is the mesh. It's the Y-shaped mesh which is formed outside the body of the patient. And here the mesh has been inserted inside the body through the port under sterilized conditions. And the anterior and posterior part or the limbs of the mesh are fixed onto the vault. And the extra part or the extra length of the mesh has been cut. Here it has been placed, the anterior limb and the posterior limb are fixed. And here closure of the peritoneum is being done. Suturing should be very, very good here again. Actually, laparoscopic sacrocolpopexy is all about suturing. When you perform it, you have to be very good in suturing and in anatomy, because the commonest complications that can happen is the rectal injury or the sigmoid injury and the ureteric injury or the hemorrhage. And you have to keep yourself prevented from this by knowing the anatomy well and having very good surgical skills. And here the peritoneum is being closed, and now the posterior limb, I'll show you how is it fixed with the tacker. So if you are not able to make the tacker available in your setup, you can use the ethibond suture also that can be used on the sacral promontory to fix the mesh. And here the retroperitoneal tunnel is there, and we are going to bury this mesh. First I'll fix this mesh onto the peritoneum, sacral promontory here. The tacker is coming, and again the use of tacker has to be very precise. When you're using it, you really have a feeling that you are doing a gunshot, and you have to be very good at your target, because you have sigmoid on the medially, and you have this ureter going laterally. So your target should be very accurate. And after this mesh has been fixed onto the sacral promontory, this mesh is then buried inside the whole tunnel. Now the peritoneum is going to be closed again with the suturing. Suturing can be done with absorbable suture, which can be vicryl. And here again, so the tunnel is being closed here, and so you can see that in laparoscopy, it seems like the whole world is yours actually. You can see all the structures, you can keep yourself prevented from many injuries, and interestingly, it seems like magic when you see the patient post-operatively, and patient seriously asks you that I am yet to be shifted to the operation theatre because she doesn't have any pain, and she can even be sent home in the evening of the same procedure. And so this is how it is then buried inside the tunnel. So quickly, I need the next slide, excuse me. Yeah. So quickly, I have very small number of patients' data, but for the last 5 years, it's the data for the last 5 years. 8 patients were done with the laparoscopic sacrocolpopexy, and interestingly, all of them came out to be very well at the end. And as a whole, there was significant improvement in quality of life. They all considered themselves, treated after the procedure. And however, two patients didn't have very good correction of the anterior and posterior vaginal wall compartment replacement was not very good, but the apical part was lifted up, and overall there was improvement in the quality of life. So what I think out of all this, that if the same procedure is actually performed laparoscopically, it can bring a lot of difference. It can give you more precision, and it's always better if we start shifting ourselves from the conventional sacrocolpopexy or any conventional surgeries to the laparoscopic surgery. And what I feel, and the take-home message is just to change yourself or transition from a conventional telephone to the smartphone. Laparoscopy is actually just like that. Thank you.
So let's now invite Dr. Amna Aziz to shed light on abdominal suspension operation for uterovaginal prolapse using an autologous facial sling of the rectus sheath. She is an assistant professor at Nishtar Medical University, Multan.
So I'm going to present the abdominal suspension operations for uterovaginal prolapse using autologous rectus facial sling. My co-author was Dr. Sadia Nazir. She is also working as an assistant professor in DG Khan. The traditional wisdom regarding the optimum surgical repair for uterovaginal prolapse in the young women who have fertility concern has changed over the last 3 decades. The prevalence of pelvic organ prolapse is 10.3% according to a study done in interior Sindh by Jokyo The objective of our study was to seek to assess the surgical outcomes of rectus facial sling procedures, then analyze the complications, then assessment of quality of life, and then in the end, establish the evidence-based guidelines for future treatment. This will definitely foster the innovation in the surgical techniques and the protocols. The method we used was a prospective single-arm interventional study that were done in 2 tertiary care hospitals, a public sector hospitals, Nishta Medical University Hospital and the DJ Khan, for the period of 1 year. We have 50 patients and 25 from the each center were included. We used the pelvic floor disability index score 20 to calculate the outcome before and after surgery. The procedure, as you all know, that after consent, a phenanstrel incision is made and a rectus facial sheath sling is harvested. The length can be vary according to the surgeon preference. Then the sling was sutured to the cervix, supravaginal section posteriorly. This was the modified approach. The traditional approach is anteriorly, but we use the modified approach and suture it posteriorly to support the uterus. Then in the end, the rectus sheath and abdominal layer were meticulously closed to ensure the structural integrity. This is the pelvic floor disability index in which we scale the symptoms. This was calculated before and after surgery. This score included all the 3 compartments, the pelvic organ prolapse distress inventory, the colorectal anal distress inventory, and the urinary distress inventory. Then we calculated these PFDI score 20 in each patient. These were our results before surgery and after surgery. When we look at the mean PFDI score, it was 43, and as we all know that if mean PFDI score is more than 10, it means that patient has substantial improvement in their symptoms after surgery. The mean operation time was 1 hour in 92% of the patients, and in 4 patients, the patient was morbidly obese, so the procedure take more than 1 hour. The surgical complications that we observed in our patient was fever in 2 patients, and 33% patient have no postoperative complication. The recurrence of prolapse, voiding dysfunction was observed in only 1 patient. So when we check the association of different demographic variables with postoperative success rate, measured as PFDI 20 score, we came to know that mean age is significantly associated with post-op success rate of rectus facial sling procedures. The parity of the patient, the BMI of the patient, and the prolapse classification do not affect the success rate according to our study. So my conclusion is that this study will pave the way for evidence-based guidelines and innovative approach to redefine the surgical management of uterovaginal prolapse, and it will offer hope and empowerment to the women worldwide, especially in a low-resource income countries and in a low-resource setting. This rectus facial sling operations can be very beneficial. Thank you.
I'm Maria, and I'll be holding the fort while Dr. Anam is presenting her poster in front of the panel of experts. Our next speaker, Dr. Novera Chughtai, she's an assistant professor at Obs and Gynae and supervisor of fellowship program of urogynae at Aga Khan University Hospital, Karachi. She introduced Build a Pelvis, an innovative and low-cost activity to enhance understanding of female pelvic and perineal anatomy. Kindly welcome Dr. Novera Chughtai.
Good afternoon, and thank you for having me here. So we were talking about complex reconstructive procedures in urogynecology, but I am here to ensure that our residents are trained well enough to do them with competence. So in order to do that, it's just a small effort that we've based our research on, and that is a modified, innovative, simulation-based technique of Build a Pelvis, a low-cost modeling activity to improve understanding of female pelvic and perineal anatomy in OBGYN residents at our institute, that is the Aga Khan University Hospital, Karachi. So basically, as we all know, the backbone of all our surgeries and us being surgeons is basically proper understanding of clinical and applied anatomy. and practicing OBGYN experts must have a true understanding of the functional anatomy of pelvis and perineum, because it's not as simple as hand or a leg. It's a complex interplay between organs, ligaments, and nerves and vessels, and their links to neurovascular structures. So understanding and making the students conceptualize actually what the pelvis and perineum are all about is very difficult, and therefore the inexperienced dissector finds himself or herself in a very difficult position sometimes, because the usual cadaveric dissection that we used to have is not really facilitated these days. And simulation has now come in big time in teaching postgraduate medical education. As in the Western world, there are various softwares, programs, games that are facilitating students to learn all kinds of pelvic anatomy, 3D images, dynamic images. But in a country like ours, I think we should think about low-cost, effective modalities that can help effectively produce teaching and learning new strategies to teach our students. And literature says that they introduced clay modeling. We've had yoga workshops based on clay modeling. But then they realized that clay doesn't really effectively stick to the bony models. It's difficult and non-reproducible, and it takes a little the excitement away from the learner. Most of the research has been on high-tech models and simulation-based models. So what we thought with our constraints was a prospective study, which was conducted at our department. We had 22 residents that we basically formed a module, an anatomy module, based on pre-reading materials, followed by lectures on pelvic and perineal anatomy, which were based on standardized atlases, followed by a hands-on workshop, which the students used to recreate the pelvic and perineal anatomy models. And we made it interesting and exciting by introducing competitions between teams and active participation of the residents. So we had 2 one-hour lectures by dedicated faculty members. And then we also administered a 20 question-based test, which was done once before the lecture, once after the 2 lectures, and then finally after the workshop that we constructed for them. And then the mean test scores were compared. So this is how we did it. This is just a flowchart of how we took the module forward. So we had 3 tests, and we compared the mean scores of all of them. This is our pelvic anatomy model. I would like to acknowledge Dr. Shaheen Britton that we collaborated with. She's an associate professor of OBGYN and a simulation expert at the Emory University School of Medicine, USA. And she very graciously allowed us to further modify her developed simulation model of the pelvic anatomy. And as you can see in our, do we have a pointer? Yeah. So in our model, this is just a bony pelvis, a fake bony pelvis, and we've used felt paper of different colors to differentiate pelvic muscles in orange, iliacus in yellow, and perineal muscles in purple, and then followed by the reconstruction with red yarn or wool for the important vessels in the pelvis and their branches, and white straws for the ureteric course throughout the pelvis. So these were our results. You can see that there is a great difference between all of the tests. When you see the difference between the pre-test before the lecture and after the lecture, the p-value is significant. So basically, the score went up from 7.14 to 10.68. And finally, the difference between pre-test, the first pre-test, and after the workshop test was 7.64, with the p-value, again, significant. So all the tests' mean scores were statistically significant, which improved the understanding. That proves it. And this is the feedback from the residents. The residents said that the objectives of the activity they understood and they took them well. They acquired and retained new knowledge. The queries were responded well by the teachers, and the overall assessment was 4.9 out of 5 because they think they enjoyed it and they think they were able to reproduce it later. So basically, when we asked them relative to where you were before this module, how are you after this workshop? And 75 to 100%, 10 residents said that they had improved really at large level. This is again a graph showing an improvement of their test scores before and after all of the module was conducted. So basically, this was a small effort. We only had our residents, 22 residents, 11 junior and 11 senior residents. And we took the tests there and then. So basically, the immediate retention was visible, but we plan to follow them over time to see how their clinical and surgical outcomes improve on the basis of these active modules that we construct for them. Right? So this was a single center study because in OBGYN across Pakistan, there's no standardized assessments of residents based on different modules and academics, but we plan to do so in future. So we concluded that this was a very good, effective way of teaching OBGYN residents pelvic and perineal anatomy, and because they were excited, they were interested, and they had a very interactive discussion through all of this week. And the postgraduate trainees in Pakistan can benefit with such low-cost strategies, as cadaveric dissections are not really facilitated due to multiple religious and social reasons and various limitations. We've done this workshop across the nation. I think many of you must have attended them. They're heartily attended. And we plan to do more of these low-cost simulation workshops on complex urogynec procedures like sacrospinous fixations and abdominal sacropexy and AP repair. Thank you very much.
Our next speaker, Dr. Durya Rahmani. She's a consultant minimal access surgeon at Aga Khan University Hospital, Karachi. She is going to present a case series on the management of hematocolpus.
So it was a case series, about 10 patients. We observed the patients with hematocolpus and hematometra over the last 5 years, presented to us in adolescent and gynecology clinic. So we all know about the background of obstructed vaginal anomalies, that they can present almost in a similar way with chronic pelvic pain or with cyclical severe lower abdominal pain, but their management depends on the type of the obstruction and the location of the obstruction. So in our study, we included 10 patients. Just for an overview, I'm describing here the vertical and horizontal fusion defects. We all know that vertical fusion defects can lead to transverse vaginal septum and imperforate hymen, and horizontal fusion defects can lead to different uterine anomalies, which are diadelphous uterus, biconjugate uterus, and septate uterus. These are the 10 patients. Their demographic, symptomology, their diagnostic imaging, and surgical interventions all are included in my case series. This table is showing total 10 patients who presented to us with hematocolpus or hematometra over last 5 years. Out of these 10 patients, 4 cases were overa, 2 were transverse vaginal septum, 1 was low septum and 1 was high septum, 3 cases with imperforate hymen, and 1 was the most difficult case with vaginal and cervical agenesis. So out of all these 4 cases of overa, they all presented to us with an early adolescent age group like 12, 13 and 16 years of age. They all have the similar presentation of severe dysmenorrhea. Associated renal anomaly was seen in almost all of the patients. 1 out of the 4 patients also had associated skeleton anomalies. These are the MRI pictures. MRI plays a very important role in diagnosing all the obstructive anomalies of the genital tract. The picture on the left side is showing a huge hematocolpus in one of the patient with overa, and the other picture is showing absent left kidney with only right kidney visible. This is another picture with biconjugate uterus and a huge hematocolpus in one of the patients with overa. This is the picture of scoliosis. 1 out of 4 patients had associated spinal scoliosis, which was corrected after surgery. All of the 4 patients were examined under anesthesia, and there was a huge bulge seen on one side of the vagina, and other side of the vagina was patent. This is the study which has described different morphology in patients with overa. Overa can present with different uterine anomalies, which can be biconjugate uterus, septate uterus, diadelphous uterus. Similarly, in our study, in all the 4 cases, there were different uterine anomalies. 1 patient had uniconjugate uterus, 1 had septate, biconjugate, as well as diadelphous uterus. All of the patients were treated by removing by doing examination under anesthesia and by removing the longitudinal vaginal septum, and they all are doing well on follow-up. 3 cases were of imperforate hymen. They all typically presented to us in early adolescent age group with severe cyclical lower abdominal pain and primary amenorrhea. Clinical examination revealed a bluish bulging membrane at the introitus, and MRI was done further to rule out any associated anomaly and to look at the renal system as well. These are the pictures showing huge hematocolpus in one of the patient with imperforate hymen. They all were managed simply by doing examination under anesthesia, and cruciate incision was given at the hymen, and the margins were stitched back, and hematocolpus was drained. All patients are good, and they are doing right on the follow-ups. There was one patient with transverse vaginal septum. She was a 12-year-old female. External genitalia was showing a blind-ending vagina, and baki tenor staging and all other features were unremarkable. This is the MRI picture showing transverse vaginal septum along with the hematocolpus. This septum was low in vagina, so she was also treated easily by doing examination under anesthesia and excision of the septum. A transverse incision was given on the septum, and margins were lateralized and stitched back to the vaginal wall. Septum was present 2.5 centimeter above the introitus, and after resection, Foley's catheter was placed with the help of a balloon to maintain pressure and to secure hemostasis. The patient remained well post-operatively. Different studies have demonstrated the role of MRI in the diagnosing of transverse vaginal septum. MRI plays a very important role not only in the diagnosis but also in identifying the location of vaginal septum, whether it is lower in the vagina or middle or higher. This is a case with, who presented to us with the vaginal septum that was quite high, and the lower part of the vagina was not formed, so it was also associated vaginal agenesis. She was a 14-year-old girl. On examination, external genitalia, vagina was looking like blind vagina, and on rectal examination, a bulge was felt anteriorly 4 centimeters above the anal opening. This is the MRI showing hematocolpus with transverse vaginal septum, and the lower part of the vagina was not formed. Surgery was done, examination under anesthesia was carried out, and cruciate incision was given on the vaginal dimple through the vaginal root. Vaginal reconstruction was attempted, but because of the difficulty of the procedure, abdominal approach was also adopted, so laparotomy was proceeded. Bulge in the upper 1/3 of the vagina was identified from above, and it was incised and all blood was drained. Dilator was used from above to reach up to the lower 1/3 of vagina as well. Vaginal reconstruction was done vaginally by peritoneal pull-through technique, and Foley's catheter was inflated and was put in place to maintain patency. Patient was discharged. She did well on follow-up. Vaginal dilators was also advised to keep vagina patent and to prevent vaginal stenosis. Different studies have described that distal vaginal agenesis, outcomes of the surgery in distal vaginal agenesis depends on the length of the vagina that is absent. If it is less than 3 centimeters of vagina that is absent below the septum, outcomes are usually good. But if there is more than 3 centimeters of vagina, which is agenetic or it is absent below the septum, there are more chances of developing vaginal stenosis after surgery. Similar, we also observed in one of the case. This was the case, a 12-year-old girl presented to us with vaginal and cervical agenesis. The MRI is showing a uterus with no vagina and no cervix. Distal part was completely agenetic. External genitalia were normal looking. As you can see in MRI, uterus is full of blood with hematometra. Cervix and vagina were completely absent. Initially, examination under anesthesia and diagnostic laparoscopy was done, which revealed a uniconvex uterus. A needle was inserted into the uterine cavity. We tried to drain the hematometra, but it failed. Later on, patient and her parents were counseled about the findings, and she was given medical treatment for suppression of menstruation. Later on, vaginoplasty was done by pull-through peritoneal technique, but after 3 months, she again developed vaginal stenosis and presented to us with severe pain. After 1 year of medical suppression and painkillers, finally they opted for total abdominal hysterectomy, which was done due to complete vaginal stenosis and persistent abdominal pain. There was absent cervix and vagina, and the uterus was removed. Later, histopathology also confirmed the absence of cervix. This was the most difficult case that needed 3 step-by-step surgeries to remove the pain of the patient. So we conclude that severe dysmenorrhea in early adolescent age group should never be ignored. Imaging plays a very important role in diagnosis. In obstructive anomalies, treatment is almost always surgical. And in young adolescents, we can use medical treatment for suppression of the symptoms and to gain time for decision making. Thank you.
So let's keep the momentum going by welcoming our next presenter. She is Dr. Shakila Yasmeen, Head of Department OBGYN at Qaid-e-Azam Medical College, Bahawalpur. She compares outcome of modified Davidoff and McIndoe vaginoplasty techniques with a focus on surgical success and female sexual function index.
Assalamu alaikum and good afternoon, everyone. I would like to say thanks to Professor Nazli and her team for giving me this opportunity, and a huge appreciation for organizing this wonderful academic session. So let's start with our discussion. This is my humble introduction. I take keen interest in urogynecological and pelvic reconstructive surgeries, and my special interest is in the vaginoplasties, and I am performing vaginoplasties for the last 20 years. So it's a decades-long journey. So my first study that was published in JCPSP was a decade-long study that was from 2005 to 2016. In that study, we compared just the anatomical outcome and the complications between the two methods of the vaginoplasties. But as the time evolved and the surgical expertise grew, then we started to concentrate more on the Davidoff's vaginoplasty. The reason behind was the female sexual function index was never been considered, and this is the point that was least talked about, especially in our setup. So I just started to work on this, and we conducted this second study. This is the comparative outcomes of modified Davidoff's and modified McIndoe vaginoplasty techniques in patients of MRKH. I have nothing to declare, and all of you must have very good idea that MRKH is a syndrome that affects in 1 in 4,000 female live births. It's absence of uterus in the proximal vagina. It has very serious impacts on the physical, psychological, and the social implications. Vaginoplasty is crucial for improving the sexual function, peace of mind, and overall quality of life in these patients. The objective of the study was to compare the surgical outcomes, feasibility, and female sexual function index of modified Davidoff's and modified vaginoplasty. That a decade-long study ended up with very good results, but later on I felt, as my expertise grew, that this was the factor that was not taken into account, never talked about even with the patients when they come to me after a long time in their long-term follow-up. So this is a prospective comparative study conducted at BVH from January 2021 to December 2023. The study enrolled total 40 patients, 20 patients in each group. Consecutive sampling was applied. In modified McIndoe vaginoplasty, new vagina was created by blunt dissection in the rectovesical space, followed by the insertion of the hard mold. That is an innovation that I have created 2 decades back. I will show you the video. It's a hard mold made up of 20 cc syringe covered by the sophratulae. In modified Davidoff's vaginoplasty, we create the new vagina in the same way, but we give a small phenol-steel incision. We look at the uterine buds, they are present or not. If they are present, we just preserve the uterine buds. We go for the salpingectomy only. We preserve uterine buds and the ovaries, and we mobilize and utilize the anterior and the posterior peritoneal folds, mobilize them along the new vagina, and stitch them to the introitus. I also work in a public sector hospital, so laparoscopic surgery can be done on the Davidoff's, but we prefer the small phenol-steel incision because of the low resources and the economy is the basic reason. This is the, beta ye pointer kahan hoga? So these are the pictorial presentation. First picture is showing the vaginal agenesis. And second picture is showing the dissection in the rectovesical space, creating a new vagina. And third is showing the hard mold covered with the sophratulae. And fourth picture is showing the fixing of the mold. After 7 days, the mold would be removed, and all the patients were placed second mold for the next 2 weeks, again covered by the sophratulae, and Foley's catheter will kept in situ for 21 days. After 3 weeks, we will remove the mold and Foley's catheter and would send all the patient to home with advice of to use the homemade mold. This homemade mold is again made up of 26 syringe covered by the roller gauze, and that is again covered by the condom. She will change the condom daily at night and will place the mold in situ in the new vagina for the whole night with the help of panty, and she will remove it in the daytime. And after 3 months, married women were allowed to have sexual activity, and unmarried patients were advised to use this mold daily for 1 hour at night for next 3 months. And after 6 months, they would use this mold only for 1 hour on alternate day. We followed the patient monthly for 3 months, then 3 monthly for whole 1 year. These are the results. Demographic data is almost comparable in both groups. Regarding the operative complication, intraoperative and postoperative, they were also comparable. However, the Davidoff's vaginoplasty took a bit longer time, but you can see the Davidoff's vaginoplasty showed a significantly very good result regarding the length and width of vagina at 21 days and 6 months. Similarly, if you come on to the female sexual function index, the Davidoff's vaginoplasty shows a significant improvement, especially regarding the arousal, lubrication, and orgasm. And the patient who underwent Davidoff's vaginoplasty showed the lesser painful sex, so they have lesser dyspareunia. If you look at the FSFI score, it was more than 30 in 60% patient of the Davidoff's vaginoplasty, and it was between in McEnroe vaginoplasty, it was in the 40% of the patient. The nutshell of the study is that the patient who underwent Davidoff's showed the FSFI of more than 30 in 60% of the patient, and FSFI was 25 to 30 in 25% of the patient, and FSFI, that is lowered satisfactory index, was seen only in 15% of the patient. So this study highlights the advantages of modified Davidoff's over modified McEnroe vaginoplasty for women with MRKH syndrome, especially in terms of anatomical outcomes and sexual satisfaction. It has better female sexual function index, especially lubrication, orgasm, and satisfaction. They show lesser dyspareunia and lesser cases of vaginal stenosis. Limitation is again same, that is a single center study with small sample size. We recommend modified Davidoff's vaginoplasty in patients of MRKH because they are having higher FSFI, and we should train the surgeon in both techniques, McEnroe as well as Davidoff's, so they can prioritize, they can align the patient's requirement according to their surgical expertise. However, the follow-up should be much longer. We recommend that at least 5 to 10 year follow-up, because my previous 1 decade long study dragged me to do another study, because I came to know after 10 years that one factor was missing in my previous study. So now I recommend that after vaginoplasty, we should follow our patient for at least 5 to 10 years. These are references. This is my YouTube link. All of you can have all the surgical steps, and all the surgical videos are available on this link. You can see. And please video play kijiye. This is 8 minutes well. Video play kijiye. So this is the, in CN, I'm showing you the vaginal agenesis. Our vaginal dimple is almost always present in the patients of vaginal agenesis. You are supposed to give a transverse incision just below the vaginal dimple, 2 to 3 centimeter transverse incision, and you will, I used to do the blunt dissection to create a neovagina in the rectovesical space. I use my index finger in a rotating movement, keeping my index finger anteverted towards the bladder, and assistant would be placing her finger in the rectum throughout to avoid the injury to the rectal mucosa. Then after creating the new vagina, we will move towards the abdomen. We will save the uterine buds, remove the fallopian tubes, and we will make the flaps of peritoneum. This is the anterior peritoneal flap, and this is the posterior peritoneal flap. And we will just hold both these flaps with the suture and the long artery forceps. And the assistant on the abdominal side will just hold both these sutures with the long artery forceps, and the assistant on the perineal side will just hold the tip of that artery forceps. This is, you can see the low resource text which we are using for the last 20 years. So Laparoscopically, it can be done easily. It's a bit difficult on laparotomy because the assistant and the surgeon should have a very good coordination to avoid the injury to the bladder or the rectum. Alhamdulillah, I'm doing for the last 20 years, not a single VVF in 20 years. All is documented in our unit. We are having large number of referral from whole the South Punjab. So diverting the peritoneum towards the perineum, and we will just stitch both these folds. Anterior fold will be stitched to the anterior, along the anterior wall of the vagina, stitched to the ostium, and the posterior fold will be stitched to the posterior wall of the introitus. Just show quickly how I make the mold so all can see. Just switch this to the next slide, please. Next. So this is a creation. This is our innovation, how we make a mold. Please play the video. So we take a 20 cc syringe. We cut the upper end of the syringe and make the margins smooth with the knife, with the same blade. We measure the length of the syringe with our finger and make 2 holes on the lateral wings and pass the needle to be sure that the holes are intact. Then I cover these margins with the sofratule so that these sharp margins should not cause pressure necrosis to the bladder or the rectum. So this tunnel is very important because we used to wash the vagina on alternate with povidone and the normal saline through this tunnel of the 20 cc syringe. We just fix the both things in the vulva with the silk, and we used to wash the vagina on alternate day with povidone and the normal saline. Thank you very much for listening to me.
So next, we look forward to hearing from Professor Nudrat Sohail. She is an accomplished obstetrician, gynecologist, and Director of Medical Education at Amiruddin Medical College, Lahore. She discusses the use of amnion grafts in vaginoplasty.
Thank you very much, Professor Nazli Hamid and her team for giving me this opportunity. So what I have to present, just like Shakila said, I have been working in a lot of different hospitals all over Punjab, and my most lengthy tenure was at Gujranwala Medical College, which is like say 75 to 80 kilometers away from Lahore, and we had a non-teaching hospital over there with a very simple district headquarter hospital, which is now, after 7 years, now I am back in Lahore, it's now a teaching hospital, right? So we had a lot of patients presenting with primary amenorrhea. The cause was congenital absence of the vagina. So we thought that we should be doing these surgeries over there and not referring the patients to Lahore or any other bigger city. So I'm over here presenting a case series of about 20 patients. We have been doing this at Gujranwala at Lahore General Hospital and one of the private hospitals from a study period ranging from 2017 to 2024. What I feel is that the most important thing is that the patient and the attendants must be counseled for the surgery, what is to be expected. It's going to be long, and their compliance and their cooperation is needed, and what type of a tissue is to be used. To my surprise, patients often reject when they are offered a skin graft. They're not willing to go for a skin graft. They have their own reservations, like having a scar later on, or maybe some other infection. So with the amnion graft, they're very satisfied and they're very comfortable with it. So counseling for the procedure is very useful. Our study objective was quite simple, that we wanted to create a new vagina, cover it with amnion, and then follow up these patients. The follow-up period was about 6 months to 1 year. Amnion, I think, is a wonderful tissue because it's so easy to obtain, especially in the obstetrical setup, because patients undergoing elective cesarean sections, you can have the placenta very easily. And the amnion is good because it is non-immunogenic, it lacks the antigenicity, and as such, it causes low pain and less of inflammation. Moreover, it attracts the collagen and the fibrinogen, and which is a beautiful base to have some texture and a covering. So that is the beauty of amnion. So this is how easily you can obtain it. From, you can plan the surgery on days when you have a number of elective cesarean sections, and you can, obviously all the patients are screened for hepatitis and HIV. So this is how you obtain the placenta. You wash the amnion once it's separated multiple times in normal saline till all the blood is removed and all the tissue that is more than the amnion is removed. You put them in betadine. We have been doing differently. I've been going through literature, how the people, they acquire and they make the amnion, and we have also been modifying how the amnion can become more useful, and we can have bigger pieces of amnion. So we did wash them with betadine and then re-washed it with saline, and finally we placed the amnion in saline with ceftriaxone and flagyl for about 30 minutes before it is ready to be used. So finally, the amnion, when it is ready to be used, you keep it in the same antibiotic solution in the saline, and you just bring it out when you are ready to place it with the mold. This is the diagrammatic presentation that what we want to do is, as Dr. Shakila has already told you, this is how we make a transverse incision at a place where the vagina is supposed to be. There are two ways that you can make the vaginal tunnel. Either you go in straight, bluntly with the finger. You can do it with sharp dissection. You can take benefit by not dissecting this median raphe over here. You can do it afterwards. So this is how you do it, because if you, like say, dissect it early in the part of the surgery, you will have more bleeding. However, if you will leave it for later dissection, you will have less of the bleeding. So this is the whole diagrammatic presentation, what you would like to do, creating a new vagina, placing a mold, covering it with amnion. So we have few pictorial steps for you to show. This is the vaginal patient with vaginal agenesis. Very important point over here is to leave all the skin margins, especially the lower margin of the introitus, intact, because this is the key point later on, which is going to give very good construction and a smooth, painless tunnel for the patient. So here is the incision is already made. You can instill adrenaline and it can lead to less blood loss. The dissection, either you can create two small holes, like I said, with blunt dissection with your finger, or you can do sharp dissection. It depends on your expertise. The learning curve for this procedure is quite simple. After few surgeries, you are in a very good position to do it either way, and you can use the dithermy as well. To protect the urinary bladder and the rectum, initially you can place, I would always like to place the Foley's catheter, and in the rectum you can place the Hagar's dilator, but later on, as your expertise would develop, you would not like to keep the Hagar's dilator, but the dissection has to be careful. The whole important, or the whole time taken in this surgery is really how you would create the new vagina. So once the vagina is constructed, you look into the length, how much length of the vagina you are able to do it. Because it can be 8 centimeters, it has to be 10 centimeters. At times you can create even up to 12 centimeters, but it really depends on patient to patient. And there is going to be some retraction of the tunnel that you created at the time of surgery later on. Mold can be of different types. You can use the syringe. As Dr. Shakila said, we have been using the syringes. You can modify how to make holes in it. You don't need to make even holes on it. You can use the foam, the ones the plastic surgery people use it. We have been using them. You can simply have some gauze pieces and get them covered with 2 sets of the condoms. So we have been using different things. It is how you modify it and how confident you feel, but one thing that we noted is that the initial mold has to be a little softer, because if you apply a very hard mold initially, that is very uncomfortable for the patient. Although the patient does not complain much, the beauty of this surgery is that the patients are quite comfortable with this thing. So once the mold is placed, then you cover it with amnion and place it in. Amnion, you can stitch it with the vaginal mucosa. You may not have to stitch it with the vaginal mucosa. Both are okay. Finally, either you bring both of the labia majora close together, approximate, and stitch them together, or you can just stitch either way. So in our patients, the total duration of surgery was about 40 to 60 minutes. No major intraoperative complications. If you are careful, they are not encountered. One of the patient had just a length of 4 centimeters at the follow-up, and she underwent a repeat vaginal dilatation. The limitations, you can see, we still feel the size of the sample is small to comment a lot about it, and the follow-up was not more than for 1 year. Our recommendations for this simple procedure is that acquisition and preparation of amnion must be planned prior to the surgery. Dissection for the new vaginite may be facilitated by keeping straight in the plane of dissection more towards the cephaloid part of the patient. Skin margins of the introitus must be preserved. The bladder and the rectum, they can be like, say, contain the Foley's catheter and the dilator in the beginning, and later on, as you acquire the experience, you can do it without them. And the labial folds, you can keep them approximated together with silk or vicryl. Initially, we kept the mold for just 10 days and then removed it and sent the patient with the direction to use the dilators on her own, and which was quite well taken by the patients. We conclude that vaginoplasty is a very simple surgical procedure. Amnion is very easy to obtain and is very cost effective. The functional vaginal length at follow-up is quite satisfactory. It is a scar-free surgery. The patient counseling for self-care, for dilatation, and follow-up is mandatory for a successful outcome. Thank you very much.
So I would like to invite Professor Shabeen Naz Masood, a respected obstetrician and gynecologist at ISRA University and Jinnah Medical and Dental College. She highlights sexual dysfunction in women with urogynecology conditions.
Thank you, Anam. To start with, I would like to welcome Rani and Kate, our guest from England. And thank you, Dr. Nazli. And congratulations for organizing this second IRC RCOG Summit so successfully. Thank you very much. And thank you all the listeners. I know it's pre-lunch, hypoglycemia, too much of the listening. I hope I'll try to make it more interactive and would need your attention out of your mobiles. Message? So the topic of my presentation is sexual dysfunction in women with urogynecological problems. And I have some authors with myself. They are from ISRA University, Karachi campus. No conflict of interest. Doctor, can the uterus be transplanted back in my body? This question was asked by a desperate woman, 39 years old. She had a laparoscopic hysterectomy 2 years back, followed by urinary incontinence and subsequent 2 incontinence surgeries. The spouse is disinterested in her and says, sex with a hysterectomized, leaking woman is like trying to animate musical notes from an empty drum, and I do not wish to lose my manliness. A dead woman with uterus is better than a live woman without uterus and leaking. The sexual problems are aggravated after loss of uterus to the lack of partner and concerns for catching disease. Another couple who presented for a request with IUI, intrauterine insemination, because husband had erectile dysfunctions, and he wanted to hide this thing from the family and was requesting for IUI so that he can prove his manlyhood. This is the tip of the iceberg. Sexuality, an aspect of quality of life, has that gained any attention in our clinical practice? I've been listening to so many talks, and it's only Dr. Shakila who spoke about female sexual function dysfunction. So human sexual function is an essential component of life, but I think for us it's only in species propagation, not the quality of life. So objective of this presentation is to have a sensitization and importance of female sexual dysfunction with chronic medical and urogynecological disorders. And the healthcare professionals, we should be equipped with knowledge to approach the case with sensitivity and expertise. Impaired sexual function in men is a well-recognized complication of diabetes, and it was first discovered by Avicenna in 10th century AD. But when it comes to women, the philosophy is that discussing sexuality is unheard of. If you don't ask about it, it doesn't exist. In women, sexuality is still often viewed as equal to reproduction, which leaves the sexual issues unaddressed. Females have unique health needs across lifespan as compared to men. And the women, they are more than 50% of the world population. Still, they are excluded from the research as far as sexual issues are concerned due to system and cultures devaluate and dismiss their experiences. So gender role expectations can exert a profound effect on women's sexuality. Silence is a way of maintaining innocence. That means ignorance is considered as innocence. And still in conservative societies, women are considered as undersexed individuals and have to be the recipient of sex, but not the initiators. Despite the recent increasing attention paid to sexual function in urogynecology, whether current practitioners feel equipped to support and treat patients with sexual dysfunction. What are the barriers? Lack of acceptance that sexual disorders matter, privacy, limited experience and comfort of healthcare providers. That sexual disorders matter to women with chronic illness. So we have to start using this in the medicine and teaching our trainees for importance of this sexual dysfunction in women. And besides this, female sexual dysfunction is not prioritized in medical teaching or included in the examination or educational objectives. Dr. Shela is here, and she would be with me in designing future courses for FCPS. And female pelvis medical and reconstructive surgery fellowship training milestones and the American Board of Subspecialty Certification embedded sexual function under general pelvic floor disorders as sexual health majors. So I would request RCOG to include urogynecology and this sexual dysfunction things as a priority. And so would I request Dr. Nazli, as she has just established a urogynecology unit. Now, what are the issues? Issues is confidentiality issues, worries of patient about potential humiliation, perceived or real experience of rejection or disrespect, and the time constraints. This is the most important. We all doctors are suffering from next syndrome. So women reported being more likely to disclose information about their sexual health if providers did not make assumptions, appeared non-judgmental, comfortable to talk, and respectful. Now we see that post-surgery, we have been looking at the surgeries done. Despite undergoing repair surgery, sexual dissatisfaction and challenges during sexual intercourse persisted for many women. So have we ever talked about dyspareunia prior to surgery, post-surgery? Have you ever looked at the reduction in the vaginal width? Or have we ever addressed fear about sexual intercourse and the recurrence of fistula or genital tract diseases recurrence after surgery to the patients? And we need to have an ongoing counseling and treatment by healthcare providers regarding coital urinary incontinence, that is incontinence of urine at the time of sexual penetration or at the time of orgasm. How many of us know about this? Obstetric fistula, Dr. Pushpa has very nicely elaborated about it. Similarly, overactive bladder, uterovaginal repair surgeries, and postpartum period. Especially, there is a significant self-avoidance of sex, partner avoidance of sex, and impaired quality of sex life due to sexual problems compared to control. And there are very few studies about postpartum period if you look at the literature. And then the statement that we give to the women after hysterectomy, don't practice sex for 3 months, 6 months. So I don't understand where that figure of 6 months and 3 months come from. And besides, you see 43% of the women, I'm sorry, it's not showing from below, 43% of the women in Western culture, they have female sexual dysfunction and consider it as embarrassing and private topic to discuss, and hence sexual problems go unnoticed. So we decided to have a multi-center cross-sectional study in our unit, and that was about the frequency of sexual dysfunction in women with diabetes mellitus. As I said, that it's a part of chronic diseases as well as urogynecological surgery. And this is a published study. We use female sexual cycle dysfunction index and translated it and modified and piloted and translated it in Urdu. And all the interviews of 89 women were done by our assistant professor. And the important thing is that 66% of the women who were diabetic, they received awareness about diabetes by healthcare providers. They had been attending this diabetic clinic for the past 5 to 15 years. But when it came to sexual issues, 98% said that they had sexual issues. But you see, only 9% had a chance to discuss it with their healthcare providers. And most of them were very happy when they were asked about this thing. And they said, nobody ever asked about this problem that we had or our partners had in spite of visiting for 10 to 15 years. And lack of desire was the most important part. That is 43% women, they showed lack of desire. Some said children, many children, small house, busy schedule, and things like that. But lack of desire is the most difficult part to treat in sexual function, and so is arousal. There is a prevailing view that sex is the prerogative of young, fit, and attractive. We doctors need to recognize that people may be sexually interested even though they are old, ill, or disabled. This is the second last slide. Aging may affect sexuality and can diminish sexual desire and functionality. But there is no age during which sexual activity, thoughts about sex, or desire come to an end. And this is a book from one of my very good friend, Deepak Jumani from India. Sex has no expiry date. It is available on Amazon for $20 only. All of you must buy it and read it. So in conclusion, be aware that sexuality is not often a subject about which patient would volunteer information. Think about our own capabilities and comfort to initiate discussion, to inform and manage sexual problems of the women. And the most important thing is that female sexual dysfunction should be prioritized in medical teaching and be included in the examination and the educational objectives. The purpose of this presentation was not to give you any information or idea, but just to create ripples in the thoughts of our urogynecology colleagues and our doctors that we need to think about it. Thank you very much, and I appreciate your patience.
Now let's welcome our last speaker for this urogynecology session. We have Dr. Kashif Qayyum. She is a resident at Mother and Child Health Center at Pakistan Institute of Medical Sciences, Islamabad. She'll share her perspective on a comparative analysis of bone mineral density changes and climacteric symptoms in postmenopausal women with and without pelvic organ prolapse.
Assalamu alaikum everyone. First of all, this is such a privilege and an honor to be presenting in front of all of my seniors here today. I'll be presenting on a topic that addresses the intersection between pelvic organ prolapse and skeletal health in postmenopausal women. Next slide, please. Okay, thank you. Okay, so we start with the introduction of the study. We know that menopause is an inevitable part of a woman's life, but there is no reason that it has to be uncomfortable too. So the purpose of this study was to make the pathologies that are associated or that are connected with menopause a little less painful for the women who are going through it. We know that the development and occurrence of menopause, which is a permanent discontinuation of menstruation, is an important stage in a woman's life. It can be linked to different pathologies. Number one, pelvic organ prolapse that we'll be addressing here, and osteoporosis and the climacteric symptoms that can all be ignored. Given that the aging population is on rise, these conditions are a major concern, not just for women, but for public health as well. Now, the objective of this study was to determine a correlation between pelvic organ prolapse and climacteric symptoms along with skeletal health in women, like bone mineral density, to enhance the quality of life during menopause. Now, we come to research methodology. The population that we got for this research was postmenopausal women 41 to 70 years of age. Any conflicting participants were excluded from the study. Anyone who was taking any metabolism-altering drugs or with any comorbids like hepatic or renal pathologies were excluded. Now, 367 women after the exclusion criteria were included in the study, and patients especially with premature ovarian failure or any other comorbids were excluded. Demographic and the medical data was taken from the official database of MCHC PIMS. The bone mineral density analysis was done using a DEXA machine, and the climacteric symptoms were assessed using Green Climacteric Scale Questionnaire. Now, it was a cross-sectional comparative analysis, and as I've already explained that it was 367 postmenopausal women. The data that we analyzed from the bone mineral density from the climacteric green scale was analyzed using mean values and percentages, which are algebraic measures of central tendency. Now, coming towards the results. Out of 187 women with pelvic organ prolapse, 45% had osteoporosis, while 25% of the women showed up as osteopenia. And these were the patients that didn't even know that they were going through these things. They just had aches here or there. And they just showed up to us just for the problem of their prolapse, and we did scans on them. And after those scans, we realized that 25% had osteopenia and 45% had osteoporosis. Well, coming to the Green Climacteric Scale and psychosexual symptoms, 87% of the women complained of psychosexual symptoms. Remaining 10% had no association between bone mineral density changes and prolapse. Conversely, it was such a contrast when we compiled these results that in women who didn't have pelvic organ prolapse, the alteration in the bone mineral density were only seen in 20%. In contrast to 45 and 25%. Now, 38% of them complained of psychosexual symptoms, while 87% of the women complained of psychosexual symptoms, those who had prolapse. This is the same thing. There were patients who had no association with prolapse or osteopenia or osteoporosis, so we excluded them from the study. Those 10%, 19 patients. Those with prolapse, 36 of the patients had BMD changes, and 144 patients showed no changes at all. This is the same thing. Okay. Now, in conclusion, the results point towards a statistically significant association between pelvic organ prolapse and bone mineral density alterations and climacteric manifestations. It is potentially dangerous for increasing the possibility of osteoporosis, so it is critical to monitor BMD in all the women who are going through postmenopause. But to make the burden less on us, especially the women who have pelvic organ prolapse, they have like an increased risk of changes in their skeletal index. So those are the women that we have to look out for, and we have to do BMD analysis in them. Now, the enhancement of risk factors in young women, they could help optimize postmenopausal management and reduce the frequency of associated condition. Not just improve the lifestyle of the women, but also like decrease the burden that the setups in Pakistan have because of these things. Now, my recommendation would be that the presence of pelvic organ prolapse should be taken as an incentive to like dig deeper into the individualized bone mineral density index and the fracture risk assessment, especially in the postmenopausal population. And there should be continued surveillance for psychosexual symptoms along with BMD changes and pelvic organ prolapse. Thank you.